tries to diagnose COVID-19 with just only cough recordings. So an overview of the entire paper, what's there. So again, don't be intimidated by all the text, just follow my pointer and where I am pointing, you'll be fine. It's a very simple paper. So essentially what you have is a person and a mobile phone. So that person can cough in the speaker of the mobile phone, 3 or 4, it's a forced cough. Forced cough means the ones that we gave in front of doctors. And that's it, just that's it. Given this, it can actually determine whether someone has COVID or not. So it's essentially non-invasive in the sense that the people who have gone through a COVID test, they stick something deep inside your nose. It can be very invasive, it can be very painful, it can be very irritating. It's essentially free. Free means like it almost costs nothing. You just need to install the app. The traditional COVID tests are substantially expensive. It's unlimited throughput. That means that, again, as you have heard and saw in the news, that the results are coming out in like 3 days, 4 days. People have missed their planes due to that, but it does not have any of that. The system, it will just give you result instantly. That's the same thing, the real-time results, and you can put as much test as you want through the system. It's practically, it's limitless, its capability. Also the longitudinally monitor, that means that you cannot, again, you can have a profile with them, just like a Facebook account, and then you can like monitor your pattern for a long time, like over a month. And what will you monitor? We'll come to that. But the idea is that your symptoms, your condition, they can be monitored for a longer time. And that can be actually especially helpful for the people who have suffered COVID and they're not entirely sure how they're coming back, whether it has affected them. So it has other implications beyond just detecting COVID. There is a very complicated looking model. We'll come to that. And a result will also come to that. So we'll describe it later. Just coming to the performance, it has around 98.5% sensitivity. So sensitivity means that, like, imagine like in a room, like maybe 100 people have COVID. There are like 500 people and 100 people have COVID. So from that 100 people, it will be able to determine like at least 98.5 of them. So it may miss like 1.5 people, but most of the people, the overwhelming majority, it will be able to determine that they have COVID. And 94.2% specificity, that means that it's a false positive. So again, going back to the previous example, there are 500 people, so 400 people don't have COVID. So it can miss some people. So if it says that like you have COVID, then there is 94.2% chance that you have COVID. It will miss like with around 6%. So for some people, it will give false positive. It will say that you have COVID, but you don't have it. But the point is that it's actually pretty good because the standard PCR test, their performance is similar. Even in some cases, it's actually much lower. So in comparison to the standard tools that are being out there, that are being used, it's actually pretty good. It has around 100% asymptomatic detection rate. We'll come to that. But the point is that the people who are not showing any symptom, it can actually determine them with 100% certainty, accuracy in their data set. That's actually very crucial because it can help you detect the outbreak early when people are not showing any symptoms. So that's actually crucial. The why use cases, it's actually related to the features, is that it again, that all the people in the US, they can do the test every day. It costs very little. So you can have the daily countrywide screening. You can have a very good outbreak monitoring system. For example, in the UFR, in the campus, again, as it has like very good sensitivity and specificity. So they do a lot of math to prove it, but the point is that if all the people do this test regularly and some people like come up positive, and then you can do like a more rigorous testing on them. So essentially, you can actually monitor the outbreak in a very cheap manner and in a very early manner. That if a little bit of people are showing COVID symptom, you can quickly determine who they are and so on. So that's also related to a test pooling candidate. That means that, again, you can very easily and very quickly determine, okay, these are the people you need to test and so on. So that's essentially the entire feature. So it looks good. So I'll come to the data set. There's a lot of number there, again, don't get afraid. So there are like around 5.5K patients, almost equally positive and negative. They discarded a lot of negative to make it equal. And HIT means accuracy. So within this group, for the positive patient, it's 94% accurate. And within the negative patients, it's the accuracy is a little bit down, around 80%. But in total, like on average, it's 86.4 on the entire data set, Now the data set has some parts. It has some male, some female, some people whose gender is unknown. These parts are not necessary, but the point is that they're roughly equal, 42%, 48%. I mean, the point is that the distribution is roughly equal. They also collected like lots of symptoms, like what are the symptoms that these people are showing, and so on. And that's where I'm coming. Like you can see it, like no symptoms or no symptoms official. And here they have like very good accuracy. So that's what they mean by no symptom, like, or asymptomatic patients. They're having 100% accuracy, at least for the people who have it. That's the important. Like these people have it. So yes, they may give some false alarm, but for the people who has COVID, even if they don't have any symptom, their performance is very good. Now they have a pretty strange way of collecting data. Is that, again, it's remote sensing, right? I mean, they've deployed the system on the wave. People have come and given their data. Now, how do you determine who has COVID, who does not have COVID? So essentially, there are three types of people. One is the personal assessment. The people who did not do any test, they just determined that they have COVID or they don't have COVID. Maybe by reading the symptoms over the internet, by hearing the talk show, whatever. But they determined that they have COVID. But the important point is that, again, you can see that the model's performance is pretty low on them. It's actually natural because it's not, the label itself is not that good. I mean, that's their guess. It can be false. But the other cases where a doctor determined that they have COVID, but they did not undergo a test, because again, you can remember there was a lot of shortage in testing in many parts of the US. For that, the model's performance is actually pretty good. It's high 90s. And the official test, the people who went through a COVID test, the performance is actually very good as well, around 97%. So that's about it. In total, it's 86%, but if you break it down into three parts, the personal assessment, the performance is not that good. For the doctor essays, it's good. For the official test, it's good as well. So that's where we are. There's the data set. That's how they collected the data set. There's the performance that they got. We'll just come to the model. I will comment it from a high level perspective, because there are lots of deep learning concepts there which are difficult to explain if someone does not have a official course on deep learning. So essentially, you have the audio, the forced cough. They tell people to give 4 coughs, and they extract the MFCC features. So what's MFCC? MFCC is basically, it's basically, again, when you talk, there are like lots of frequencies. It's one signal, but you can divide it in lots of parts. And MFCC just essentially tries to understand, okay, like maybe there are like 10 parts. How is the energy distributed in those parts? Like maybe for some people, they have like higher energy in lower frequency. For some people, it's in higher spectrum. For some people, it's equally distributed. But the point is that how the energy is distributed in your voice. Yeah, MFCC is actually a very important feature for lots of audio tasks. For some reason, it actually works very well in a wide range of audio tasks. Now they do it, they pass it. So about the model, I will just clarify certain things before going into the details. So they have a project on Alzheimer, the same group. They have a project on Alzheimer's disease. They have a model, they have a system which really works well. They have a paper. Now they're trying to connect Alzheimer with COVID. How? Essentially, when you have Alzheimer's disease, you show lots of neurological symptoms and so on. And the same is actually sort of true with COVID as well. Once you have COVID, you tend to show some neurological symptoms, maybe temporarily. For example, you don't like tend to like detect smell really well and so on. So there are some neurological semblance between both of them, similarities. And essentially, they're using the same line of thought or the system that they used for Alzheimer's for this. So how? So when you have Alzheimer's, there certain things happens, and also they also use COVID as well. So it's not just only Alzheimer's, but the point is that one is that your vocal cord is affected when you have COVID. Your vocal cord is affected. Second is that your lungs and your respiratory system, that part is also affected. And the third is basically your sentiment. So by sentiment, what they mean is the emotion that's expressed through our voice. It didn't like show up to be that much of an important feature, but it seemed to be like, okay, they also included that. Because their idea is that, I mean, the sentiment that's expressed through your voice, that may be affected due to COVID. So they essentially put 3 different models. These are ResNet 50. So these are like very high top level models for computer vision tasks, but they use it here. And for modeling your vocal cord, your lungs, and your sentiment. And there is something called a Poisson mask. And there's something called a muscular decay. So the idea is that, so what's a Poisson distribution? So a Poisson distribution is essentially, so it's trying to determine or model human behavior. Let's say you have rail station, you are trying to model, okay, how much train do I need like at various points of time. So from past data, you try to understand how the distribution of people is. Like there will be a lot of people like in the morning, or in the afternoon, or in the evening, 5, 4. There will not be that much people throughout the day. So you're trying to fit a probability to the system. And they did it with the MFCC as well. The idea is that they're trying to simplify it. The MFCC is a lot of number. They're trying to giving it a probabilistic shape. And essentially and it's actually very helpful because without it, their error rate increases like twice. And then they have all these models, like 3 models. They combine all of them. And then at the end, they determine whether someone has COVID or not. That's about it. There is a very complicated looking model called longitudinal saliency map. I will come to it later in details, but we'll come to that later. So that's essentially the model. The performance actually very good. So they use a metric called AUC. So AUC is essentially, it's called area under curve. So it's trying to understand the relationship between sensitivity and specificity. So how good your model is, there are 2 ways to determine. Again, we talk like, it's saying that you have COVID. How likely you are to have COVID? It's saying that you don't have COVID. How likely is it to be true? So a model needs to balance between these 2 pools. And the model that really, if a model scores 1, then it's perfect. 0.5 means it's random. 1 means it's 100% perfect. And their models are pretty good on that domain. It's 0.97 AUC on the official models, on the official data. By official, we mean the people who had a COVID test, and their label is from that test. By all, again, there are like 3 types of people: self-diagnosed, doctor-diagnosed, and official. That's a bit lower, but for the official guys, their performance is very good. So the model is good. That's the point. And they did like some ablation, some interpretation to understand which part is important and so on. So this is the first test. So what they did was that they have a baseline. By baseline, I mean like, for example, their data is not entirely like 50-50. It's So was it 50, 50? So essentially that's the baseline, and then whether something can work better than that. So this is basically like how much model they are training. Like there are lots of layers. So they train 0 layers, 5 layers, 10 layers, all the layers, and the complete model. So if you train more layers, you can see that yes, the performance increases. And the same is true for vocal cords. So they just removed all the other parts, just kept the vocal cords. Then they just kept the lungs model and the sentiment model. So essentially they just kept those 3 models separately and just removed everything else. They're just trying to understand how much performance is coming from the vocal cords. And it's actually very good, better than the baseline. The lungs, again, as you train more model, it's good. Sentiment, it's not that good. So the sentiment is actually very close to baseline. It does not have that much information. And the other point is that the lungs model, that's the most important. So there are 2 important things. One is that these parts have influence. Sentiment does not have that much. The lungs has the most influence. So they did some more training. So there is a thing called no pre-training. So what it means is that, again, if you look at the model, there are like millions of parameters, and you just have 5,000 data. You cannot expect it to perform really well with this just 5,000. So what they do is that they train the models on related tasks. For example, for the lungs, I believe they trained it on detecting a particular word. Maybe it was or something like that. So essentially, they trained the model beforehand on related tasks. So the model is sort of has learned a lot of things. So, and then they don't train it. So there are 2 parts. In this part, all the models were trained. Here, no models were trained beforehand. And you can see that, like, if the model is trained beforehand and then the 5,000 data is fed, they are trained on related tasks, not the same task, on related tasks beforehand, it actually performs well. So there is a value in pre-training the model or training on related tasks, which has a lot of data, as the models have millions of parameters. Also, just again, this is a baseline. They have the complete model. They have the no vocal and no sentiment. So what is this? This is essentially, again, here they just tried with like adding 1 model, and here they're trying with removing 1 model. So this is the complete model. Here they remove the vocal part, and here they remove the sentiment part. So that's it. So they're trying to understand how much the performance decrease. For example, if you remove the sentiment part, the performance does not decrease that much. But if you remove the vocal part, it actually decreases significantly. So that's something that they're trying to put you. And also, this is also, as they determined that the lungs model is the most important, they did not remove it. They always kept it. As you can see, it always has a very good part of the, like the performance is coming from just the lungs model. So that's it about this thing. So what they try to understand is that there are like lots of components in the model, right? You need to give an interpretation, how the model is being affected by all these different types of features. So that's what they're doing. Just to clarify, this is symbolic. So this is not like a real data. This is symbolic. This is trying to give you an idea of how the thing is coming up. For example, they have several parts. If you look at this part, this is just, for example, if you have just 1 cough, what's the performance? If you have 2 cough, what's the model's performance? 3 cough and 4 cough. So what they're trying to show is that as you have more cough data, then your model is performing well. You can understand that from this. Again, it's symbolic. It's just trying to give you an idea of the interpretation the model can give. It's not real data. And then there is like things like how is the prediction varying. Then there is things like, okay, for a particular person, how much performance is coming from the vocal cords, how much is coming from the sentiment, how much is coming from like the muscular degeneration and so on. So that's essentially, this graph will just give you an idea of how the prediction is made, what's the source of the prediction, how different features are varying. So that's about it. Yeah, that's about it. Yeah, so that's what I had to present. Any question?
So we're going to go over the paper exploring the adoption of telemedicine and virtual software for care of outpatients during and after COVID-19 pandemic by Mr. Boccolo. Thank you, Mr. Boccolo. So here's a roadmap for you. We're going to review the paper for 10 minutes, and then we're going to have a breakout activity for 5 minutes, basically. So to get our brains warmed up here, what are the advantages of telemedicine? Anyone have, and not during the scope of just the pandemic, in general, what's the draw? Why would anyone even want to do something like this? Oh, you.
Like, I think they just cannot, like, they don't have to be physically presented in the clinics for any screening. And, you know, if like anything can be done, if it's just like people asking you several questions, it certainly can be done through telephone or, you know, Zoom. So I think that's the advantage.
I think that is a great thing. Convenience, like you just said, you can do it from the comfort of your own home. Why not? Operational costs. You know, you don't have to go into the doctor's office. The doctor office doesn't have to put on a mask. They don't need to have a receptionist getting paid by the hour to get you into there. Operational costs are an advantage. But what are the disadvantages of telemedicine? What do you lose when you do telemedicine?
A doctor can infer a lot of information when you're face to face, and you miss out on all those details when it's remote, right?
Amazing. Comprehensiveness. Exactly. A doctor can miss out on those details. Doctors have been doing this for years upon years upon years. You're missing out on all those experiences. Also, the switching costs, getting people to go on a new platform, learn the software, even though people's like the elderly can like even use Zoom, you'd be surprised, or maybe you wouldn't be, just how much there's normally like an adversity to like switching your normal routine or behavior. And startup costs are also an issue. You know, like you need to have the infrastructure of computers, network, bandwidth. Sometimes you'll need to have special systems like for data privacy and data access. And to have all that software, you're probably going to need an IT team. So there are pros, there are cons. Depending on how developed of a country you are, sometimes it makes sense, sometimes it does not make sense. So we're going to go into the paper now. They had a nice little flow chart of what this does. So what this paper is not. This paper is not, let's go out, let's run an experiment, let's collect data firsthand. No, this data relies on secondary sources of information to do basically just a literature review search on the topic. So how they map it out is they have research question, they have a search strategy, right? It's secondary sources of information, so you're going to be searching for them. How are you going to filter them through? Well, you have inclusion, exclusion criteria. At the end of that filter, you have, well, what's the quality look like? How do we assess the authenticity, quality of this paper? After that, it's quite simply they extract the information from the paper and then they group the papers that belong to certain points that they're trying to make. In synthesis, they talk about some of their findings and then they do a little bit of a discussion. So the research questions can be broken down into how, what, and like, I think impedance, like what is impeding this from happening is a way to look at it. I'll just read it for you. How can telemedicine and virtual software platforms be adopted for treating outpatients during and after the COVID-19 pandemic? What are they? What are the telemedicine and virtual software platforms that are adopted during and after the pandemic? And what factors, little impedance there, what factors impact the adoption of telemedicine and virtual software platforms during and after the pandemic? So great, we've defined the research questions here. Now we'll go to a search strategy. It's not really anything more complicated than what are the terms, right? What are the terms and what resources are you searching through? So if you were researching this topic, what terms would you search for? It's not a hard question.
Telemedicine?
Yes, absolutely. As nailed it. Telemedicine, telehealth, virtual software platforms, digital health, virtual medicine, e-health. But yes, the very first one, Ryan, you nailed it, telemedicine. So those are the search terms that they're using.
I think they should have also include mobile health. That's a very common phrase.
And also HIPAA, just because I think that's what would distinguish just a general virtual platform from a telemedicine platform, HIPAA compliance.
Yes, I think those are both great points that the authors did not use those two search terms. They used some search strings. I don't know if that was included in there, but I didn't include them in here. But they could have had mobile health in the search strings. So I'm not sure. They might even add HIPAA. We can check real quick, or we can move on. But those are great points. I think that would help narrow down the search. So after that, they search through these things. They have inclusion and exclusion criteria. So here's their table. I'm not going to read it for you, but what I would like you to do is identify what could be the limitation of the inclusion and exclusion criteria that they're using. What did they not consider? And I'll give you, you can take some time to digest it. Anyone have any ideas? Most of them I thought were pretty straightforward. And this might not be a limitation, but I thought it could be, is that they limited themselves between 2020 till now. Maybe if they included a little bit more on the evolution of the technology, or if they went a little bit further back and they looked at, well, how was the technology, developed and used for things like this in the past? Maybe that would add some value, but maybe it's not that big of a deal. Thoughts on that?
Yeah, I was going to say it seems like they have a pretty narrow scope of studies to pull from, especially with the last criteria. I don't know exactly how much research is out there on just it seems like a very narrow scope.
Yes, I think they might have narrowed their scope a little bit too much, and that might be the one critique I have. So then they do this quality assessment criterion, and from my understanding, this was their quality check. Were the papers in the ISI Web of Science or Scorpus database? Who has even heard of this, and why is this their data assessment criterion check? Why would it just be, if it's in this thing, then it's good?
I think it filters out the predator journals. There are certain journals that you can just make a payment. They wouldn't have any peer review and you just get it published. So I believe this might be one reason. I'm not really sure though.
Okay, I think that's a good reason. I also didn't know why, but more than 50% of the selected papers were indexed in this ISI. So that's how they did their quality assessment. So where are we now? We've gone from research question, search strategy. We've done the inclusion, exclusion, the quality assessment. So this is what we kind of just went through here. This is a figure from the paper. No surprise, they have identification. These are the databases they use. They have screening, using some of that inclusion, exclusion criterion, eligibility. Again, I think they're using from that table, and then they come down with what is included. Could anyone find out why, right here where I'm circling my mouse, the additional records identified through other sources n equals 0? Why would you include that in this figure? Why do you think that? What value does this add here?
Well, it shows that they actually looked into other sources, but couldn't find anything.
That's a good point.
Ask around colleagues, perhaps.
Could be. I had thought maybe they just wanted to make it look a little bit more complicated of a flowchart. But
no, I think if a reviewer sees this paper, the first thing they would say that why don't you look at other sources? So they just make sure that they have it right there.
That's a good point, actually. That's probably why it's there. Then the reviewer's looking through, it's like, ah, I see. They looked through the other sources and they didn't find. Okay, great. So I guess going through all that is, we'll just go through the strengths of the telemedicine for the pandemic, and then that'll get us to the end of going through the paper, and then we'll break it out into our breakout rooms. No surprise, you decrease the time required to get a diagnosis, initiate treatment, stabilize. So what I couldn't understand about this is, how are they doing the diagnoses over at telemedicine if, you know, what Wasif said is when they stick that, that long, white, thin Q-tip up to like your nose, it could be like very uncomfortable. And I thought that was the only way to get diagnosed, but perhaps they just do it like just symptoms based. I don't know. They didn't really go into the details there. I assume that's what they did it. I guess it wouldn't be a for sure diagnosis. I interpret it more of like, hey, you need to come in and get tested, not like, okay, let's here's your swab that we sent to your house. Let's diagnose you right now. I think that's the right way to interpret it. So I think the follow-up is nice. You know, you get someone diagnosed with COVID, instead of bringing them into the hospital, you can check with a telemedicine. Boy, you brought this up at the beginning as a great strength for things that you don't need to bring them into the office for. Clearly, like, you reduce the movement of people, you minimize the risk of infection in general, particularly located around the hospital. Of course, I mean, maybe not so obvious, but like, if you are getting a lot more information on people that have been diagnosed and you're following up with them, you don't really need to use medical resources like masks and gowns that you would at that place. But I think maybe what this one is saying is, if you're telemedicine, let's say you're a doctor in New York City and you're telemedicine like 50 patients down in like Buffalo, you could be like, I think Buffalo is going to experience an outbreak. Maybe we should start thinking about sending them some materials like masks and gowns and sanitizers and things. So, you know, if you have them coming into the hospital, it's kind of related to the intra-hospital thing. We don't want the medical staff, the key responders, who are the biggest assets in this pandemic, to fall victim of illness. They risk their lives every day fighting it. If this could help alleviate a little bit of that stress, then, well, that's great strength. So aids in informing the general public, I think that this goes back to just collecting the data on a lot of different calls that you're having, a lot of telemedicine appointments. That's concrete data that is not data that like, oh, he said, she said from like some random place. It doesn't have to, it's not like a Trump fact check here. It's more like, hey, these are doctors that are having the calls. So this good information, they're the ones seeing the patients, following up with them. It's good data. It's good data. It's data that helps people fight the pandemic, rather than like data that like scares people away.
I think that this one is a really important one. So in Bangladesh, you know, the resources for testing was very limited, especially in the beginning. And there was obviously a lot of panic out there. So the government opened up these telemedicine helplines that you can call and talk to an expert or a doctor. I'm not really sure what the criteria was, but these helplines were available. And there were hundreds and thousands of calls to those telemedicine support systems earlier on. So people say they have a cough and they started to panic, but they cannot get themselves tested. So they just want to talk to a doctor and, you know, get get some advice on what's the right thing to do now. And also there were like other issues that are culture dependent, like we discussed previously, that hey, in Bangladesh many of the families are multi-generational and you have domestic help coming in. So all of these are like, you know, introducing a lot of confusion in people, and they want or need advice. So the calls to the telemedicine helplines really spiked. But later on, as things sort of normalized out and the panic decreased, the amount of calls really you know, decreased, and it somewhat says a lot about what's the status of panic in the country, or you know, the worry in the country. So yeah, I think informing the general public is a really important point here.
And that's a great point there, Ryan. And we've already mentioned this. You cut the costs on the medical supplies that the doctors and staffs there would be using to treat patients in the hospitals. Not sure about this last one, where they're like training of medical practitioners who are new to the treatment of pandemic. Strength, wasn't so sure on how to interpret it as a strength. I'm not sure if anyone here can help me understand, but I viewed like the training of medical practitioners to use telemedicine like as a switching cost, as a startup cost that would take away from their time to treat people. But perhaps by training them to do the telemedicine, they get to have all the strengths that were mentioned before. But unless someone has a better answer than that, please don't keep it to yourself.
Well, I guess it could be interpreted as if you're kind of new to medical practice, and before you really start interacting with clients one-on-one, you have the opportunity to work with them one-on-one from a distance. So easing your way into it, so that when you have this pandemic environment where you're working with patients, you already have a kind of foundation to start working on. So I guess it makes sense if you're kind of new to practicing medicine.
I wish I could understand what your response was a little bit better, but I think that like you've won me over with that smile. So I think yes, I think we'll go with James then on that one. So then I guess I don't really want to go through this. I want to be cognizant of the time. I think I was a little bit more long-winded than I really intentioned, but this is just like how would it look like to be telemedicine, and it's exactly what you would expect. People sign up for it, they download the software, they log in, and then they eventually meet up with a doctor. You can imagine getting on a one-on-one Zoom call with someone and they're a doctor, and it wouldn't be too far removed from what a telemedicine appointment is.
I pick a relatively refreshing template for our mental health. So my presentation is about mental health during the COVID-19 pandemic. And this is the paper behind the presentation. The paper proposes a conceptual framework which was developed by several early career psychiatrists from 16 countries, covered all the WHO regions. And so this is one of the conceptual models that they propose. It's emotional epidemic curve to depict the possible change of people's emotional behavior in different phases of the pandemic. And this is the line of COVID-19 cases. This black line is the daily number of deaths. And this red line here describes the cases with mental health issues. And there are several major points in this curve. The first one is the first peak of the cases with mental health issues. It may be associated with inadequate communication, misinformation, and fake news. And also rapid growth of COVID-19 cases may cause fear, distress, anxiety, depression, sleep disorders, and lots of other mental disorders. And for some countries, there may be show a dipping point indicative of community resilience, the rapid reduction of distress after the first peak. However, there is also a second peak. So this can be unpredictable and complex, occurring due to the death of the loved ones, economic damage, and social disruption. The dominant effects may be post-pandemic disorders, including PTSD, depression, and relapse of pre-existing mental health conditions. And there are several things to be noticed about this emotional epidemic curve. The first one is during a pandemic, people may experience an emotional contagion, which is the spread of mood and affect through populations by the direct induction of emotions. And in our deeply interconnected and digitalized world, these emotions may spread far more easily. And the second one is additional barriers for people who are distressed to obtain help may also come from the stigma against mental health disorders and also inadequate mental health related infrastructure. So many people may feel ashamed or hesitated to seek help for their mental health problems, or they even didn't notice that they have some mental health issues. And the third is that in the model I just mentioned previously, researchers have not considered the appearance of the second wave of COVID-19 reinfection, which would cause a more complicated mixture of cases. And this paper also proposed a mental health preparedness and action framework. Because of the time limit, I will just pick some, I summarize some major themes from the framework. So this framework is proposed based on the different phases during the pandemic and also categorized into different types of actions, such as planning and coordination, monitoring and assessment, and so on. So I summarized three major phases from this framework. The first one is from phase 1 to phase 3. It's mainly about planning and starting collaboration, prepare web pages, social medias to address potential misinformation, and also encourage people's constructive behaviors for self-protection, prepare virtual approaches to address mental health concerns. And the second big major theme is from phase 4 to phase 6. The direct rapid mental health activities for fear, social panic, and social distancing. Identify and develop core strategies for mental health issues, and also promote and communicate interventions. And the last one is around post-peak and post-pandemic. It's about review and share strategies and resources and evaluate all the interventions conducted thoroughly and also incorporate lessons learned into the communications activities.